Welcome to today's episode of the INEDCAST podcast. This QA session follows Dr. Sepideh Gholami's insightful lecture on colorectal liver metastasis, current management and future perspectives. Dr. Gholami, a board-certified surgeon, scientist, and national leader in hepatobiliary malignancies, shared her expertise on the latest advances in managing colorectal liver metastasis, highlighting innovative treatment strategies and emerging research. Stay tuned as we continue this discussion, delving deeper into the key takeaways from Dr. Gholami's lecture and exploring valuable perspectives on the future of colorectal liver metastasis treatment.
Thank you, Dr. Gholami. That was a wonderful talk, and we have learned a lot. The field has moved so much in the last decade. I think our audience will appreciate that. We have many thought leaders from around the world here today, and maybe I will ask to raise their hands so that we can go in order. And I'll also ask some of the thought leaders myself, who has been regular in this meeting. Dr. Abbas is from Pakistan. Dr. Abbas, please go ahead.
Thank you. Thank you very much. Very nice talk. Really enjoyed that. Thank you. So when we are giving therapy by hepatic artery infusion pump, so these tumors would disappear with time. Mm-hmm. And so some people feel like that you have to resect tumor even after disappearance because some residual tumor remains there. So what is your thought about disappearing tumors after the infusion therapy? And do still we need to resect these tumors or not?
That's a really good question. Actually, I think, I think it's challenging because some of the therapies work too well nowadays. And so I think when a patient's tumor is very small, I think you have to really be able to time the amount of chemotherapy. So I think resecting tumors that are disappeared is hard because it's not recommended that you blindly go and just resect liver parenchyma, right? The idea is to preserve parenchyma. We've learned that the more parenchyma you preserve, the better it is for the patients. You have more liver in the future, it's healthier, and you have more chances that in the future you can do another resection. So in general, no, if a tumor has completely disappeared, I do not, go and resect blindly. I think what another tool that we use sometimes here is, place a fiducial into those that are small. And so when I know already a tumor is like borderline, like a centimeter, and I predict that with the chemotherapy, it will become 5 millimeters and I won't see it or it will completely disappear, then I think one tool is maybe put like a small little gold fiducial by interventional radiology beforehand, and then you can go and maybe burn that. But the truth is you can't always do that, right? And so with disappearing mets, the adjuvant therapy becomes important. So that's why I think in some of these patients where I think the tumors have become so small or they've disappeared, I do actually offer them adjuvant pump because that gets rid of the micrometastatic disease that can recur. Because we know if you look at the path, it's about like 25 to 30% of those disappearing mets recurring, right? So I think surveillance is very key, and having like a ctDNA marker where you can maybe get that recurrence earlier and predicted might also help. But blindly resecting is also not the way to do it. So it's a really important and challenging question that you bring up.
Thank you so much, Dr. Abbas. May I invite Dr. Dharmesh Kapoor from India? Dr. Kapoor.
That was super, Dr. Gholami. I am a practicing hepatologist in India. Unfortunately, we don't get involved in the multidisciplinary team meetings to discuss the colorectal metastases. This still falls under the domain of the surgical oncology colleagues. But so much to learn and so much going on in this field. That's absolutely breathtaking. So if I understood your talk correctly, are we now suggesting that if the infusion pumps are available, then even the conventional chemo be given by way of this? Or did I get it wrong?
No. You're right. So I think it's not what we do is so the chemotherapy that goes onto the pump is FUDR. The conventional chemotherapy that is either FOLFOX or FOLFIRI, like whatever the cocktail is still given by infusion. So the way we do this is when the patient goes to infusion center, they get their pump filled with FUDR and they get the systemic. The pump gets filled only once a month because it's very toxic and it's 400 times at the concentration of what you would systemically give. And the systemic is still every 2 months, every 2 weeks. That's just the general, FOLFOX regimen for those patients. So the drugs are slightly different and the dosing is definitely very different. And when we give the pump therapy, the systemic dose is lower than the general patient who just in the community gets the systemic only. We definitely dose reduce to really mitigate the side effects.
Right. Thanks so much for the clarification. A great talk. I think one will have to go back to your slide deck and slowly understand and absorb the
Yeah, sorry, it
import
was
of
like
your
a
words.
lot, but I was trying to really give the whole breadth of overview.
Yeah, but it was superb. Thanks so much. Cheers.
You're welcome. Thank you.
Dr. Kapoor, is in India, is any centers doing hepatic artery infusion at this point?
Not that I know of, Sanjay. I'm not aware of that. And in fact, I logged in today because A, I wanted to learn something new, and two, I was wondering if Dr. Gholami would also speak about transplantation for colorectal liver metastases. Again, a very, very hot topic. But our center, we are not doing, but I just wanted to see, if there are others who are doing this and what their experience has been like.
Yes. Well, we talked about Dr. Gholami and we kept it for another talk. Dr. Linne, I think Paldag Linne from Netherlands is giving a talk on colorectal liver metastasis and liver transplantation in the coming weeks. So that's why we kind of kept it separate.
Yeah.
All right. May I invite Dr. Benedict Maliakal from Nashville, prominent hepatologist.
Thank you. That was a fantastic talk. And I think, when I hear these kind of talks, it looks like many places the patients do not get the full breadth of, treatments. And in smaller towns, etc., the local oncologists probably don't do all the stuff that we do. So there's such a diversity of care and and outcomes, therefore, and that's one thing that probably needs to be bridged.
Yeah.
Go
ahead.
Yeah. Coming to, is there any potential for using intraarterial immunotherapy into the liver along with TLR9 agonist or something of that nature? That's one question.
Yeah, it's a good. I think for your first comment, honestly, like I have to really tell you, like it's really sad to see the sort of discrepancy in care. We even see it here. Just 2 days ago, I received a call from a medical oncologist who went to one of our community hospitals here that is affiliated, and it's a county hospital. And there was a patient with like 4 or 5 small lesions, completely resectable. This is like one of the best patients I could see, and was told that that patient is going to die because there's liver mets. So I think it's what you're bringing up is absolutely critical, that not a lot of people know really how to manage this disease. And I think one of the biggest things for me is really, like, in my career, hopefully have some sort of impact of like educating and bringing the word out that, they should not be given the death sentence. So we transfer that patient, and, we will honestly have a very good outcome with this patient, and potentially even cure him. It's like, so that's the huge discrepancy, right? Obviously, a lot of the So one is knowledge, two is the therapies, like you mentioned. Not everyone has regional therapies in addition to just the conventional chemotherapies. And we need to do better to really increase the, like basically all the treatments that we have. And we're trying really, even at Northwell, we're trying very hard to, we are just actually looked at regional differences in our therapeutics for just patients with colorectal liver mets. And I can tell you that even on the surgical aspect, patients are not getting referred to the surgeons to even evaluate. So a general surgeon may just say, you're going to die, like in this scenario, but a liver surgeon has never seen the patient to actually be able to make a really educational comment about that. So I think that's really important, that we definitely need to really address like the discrepancy in care. Your second comment, so the TLR9 agonist is actually, it's an immunotherapeutic,
Right.
because it really decreases the macrophages. So our hope is maybe in some due time, put other agents through it. I think this is sort of the beginning. It's going to be very exciting. We have another device here that's a really tiny micro device where you can put like small little drops of different immunotherapy drugs into the device and then place them in the liver and then see if you get some responses. I think with that sort of trial, we can hopefully come up with to see which drugs, because the reality is we just don't know what drug would work. And it's very expensive to do these big trials where you just, give a random drug. That's why I think we need the animal models. We need to really build the rationale before we do the trials, and then after millions of dollars, they fail. I think America has been very good at that. There's a lot of phase 1 trials that lead to nothing. And so we're trying to just be a little bit more thoughtful about, do we have a signal somewhere? Start slow and then, expand it to a bigger thing. But my hope is, yes, that we put new drugs through these catheters and pumps. I mean, FUDR is old and it's toxic. And so if we can figure out better drugs to put in these pumps, I mean, people are working on it. So hopefully.
And one last question, some of the colon cancer at younger ages, etc., may be related to obesity and insulin resistance, etc. So I guess the microbiome is involved in that, but
Yes.
is there a role for, GLP-1 or other things, obesity management along with, colon cancer management?
There's a lot of focus now on microbiome, and that's why I showed that one slide. Samir Bayers' work is really focused on early onset, and he's trying to figure out whether the microbiome has something to do with it. I haven't seen a true correlation with obesity and the early onset, honestly. I can tell you that the majority of my patients now are in their 30s and 40s when they're in my clinic. Like, it's completely changed. What used to be 60s and 70s now is like everyone in their 40s has liver mets. And they're not all obese. So I don't know. I think it's something that we haven't really figured out. It must be something microbiome, environmental, something else, nutrition related. Like, I think we definitely have to do more research to really figure it out. I don't think we've really cracked that code yet.
Thank you. Thank you very much for the great time.
And thank you. I think that is what we're trying to do. Knowledge is power. I think hepatic artery infusion today, what we talked about, and many even countries, that's why I asked Dr. Kapoor, that many countries even not even doing this. And maybe this is an eye-opener. The knowledge probably that we're sharing today will help to do more research in this area and also bring it to our community. So I will ask Dr. Prasoon Jalal from Baylor to share your insights, Dr. Jalal.
It's a great talk. I really appreciate it. Now, you touched about the transplant part. We'll discuss later. Obviously, we're very interested in that. Now, coming back to the pump.
Yeah.
You tried that even for HCC or cholangio. You mentioned the toxicities. One of the major toxicities we have seen is biliary complication. So you didn't touch base in much about the side effects and toxicity part. Yeah. I mean, what do you expect? Because obviously our surgeons in our setup,
Yeah.
And as the transplant is evolving in this area, they don't want the bile duct to be damaged or disintegrated. So any thoughts on that?
Yeah, sure. Yeah, it's a good question. So we basically, I can tell you the biliary toxicity is about 5%. So when it's there, it's serious, but it really is not as common. And so I think you have to really, the reason I emphasize on this teamwork is that it's really hard to have a good program because it requires an absolute dedication to weekly lab reviews. So I meet with my team every week. We review every single patient and all of their dosing. And so we have a very specific algorithm of when to skip, when you can. So you have to be careful. And I think the biliary complications come when you don't have experience. Now, sometimes it's unpredictable, right? Like drugs and toxicities come, and I've had a patient who gets one dose and their numbers go up and we stop. And nobody knows why someone can get 6 doses of FEDR and be fine versus somebody who's not. And these are non-touched, non-resected patients. So I think the challenge is some of it is unpredictable, but the range in general is 5 to 10% if you look at the literature. And I still think it might be a really nice way to bridge. So there was to transplantation. I'm a proponent of transplantation in the right population. I think the transplant data is very exciting, but I think we have to be very careful, right? Because there's not that many organs. And we have to make sure that you're really increasing cures and not just sort of like changing the survival a little bit, but can be also done with resection. So there is, and you have this, the fine selection takes time. So a lot of the transplant data, if you look at it, it's like, oh, okay, they were very highly selective. They waited like over a year here, and then they did this much chemo. So yes, I think we just need to be thoughtful about how we're doing it. We at Northwell, we have actually 2 patients here who had the pump and are, basically have unresectable disease, but it's very minimal disease. And those patients don't have any biliary toxicity, and we're really hoping that we're going to get them on the list soon. So I think it just needs to be thoughtfully done. And hopefully with that and just experience, you can manage it both.
That's great. No, I appreciate that. The main reason I was wondering about it, because hepatic artery is one of the major supply for the bile ducts. So we just always worry about manipulating the hepatic artery from the liver side. But yeah, that's fantastic, outstanding talk. Thank you.
Thank you.
Thank you. We have a few, I believe, hepatobiliary surgeon in the audience, Dr. Badim from MIMO. Dr. Badim, would you like to share your insights? I hear that you are trying to open a HI program at MIMO.
Yes, actually, hi, it was great talk and it's very interesting thoughts. And we just in the process to start, and I see a lot of maybe it's need a lot of effort, and it was interesting how in terms of staff do you need to involve more people to really to take care only of those patients who is an HAI therapy. But you shared your experience. It was very great. So we hopefully will reach that level, and I think if you give some clue, some how to overcome those obstacles, would be appreciated.
Yeah, I don't know if I have all the crack code, but there is a publication. We just published a paper last year where I wrote sort of what are the components of building a program. So I'm happy to share that paper with you. And if I can be of any assistance, I've helped other surgeons, other teams with building a program. I mean, that's like sort of my passion. So if there's anything I can do, I'm happy to meet even offline and help, because the more patients we can get this type of therapy to, the better it is for everyone.
And in your everyday, you mostly what percentage you do open and you mentioned also you do it robotically?
Yeah. So for the robots, so we're starting with the robots because this program was relatively new. I needed to just make sure that our team like has good outcomes, and so we've done the ones we've done is like they've been all open right now. But I know other centers, who had like a longer time experience, they're now doing robot, and it's certainly safe if you have the robotic experience. We'll probably start like this summer with the robot. We just discussed it literally 2 weeks ago that we're at a time and like a number that we think it's safe to move to the next level. And it's nice for the patients, where you're just putting the pump, like you're not doing a lot of liver stuff, then they get out of the hospital sooner. Some of the bigger resections that I do, that are complicated, there's like 10 lesions and you have a pump and you have the colon, it's too complicated to do with a robot. So I think, again, patient selection is important.
The last question, have you ever thought to use it for HCC?
Yeah, so, we don't, the outcomes are not that good for HCC, unfortunately. They do it in Asia. There's several papers and trials actually in China and beyond. But I think the tricky part with HCC is the underlying liver is really just not that healthy to begin with. And so, it would be a very sub-selection of patients that would even be able to receive it, because if you have portal hypertension or like a fibrotic liver, we don't put the pump in, even for patients with cholangio. And most patients with cholangio don't have it. So that's why I think the results are nicer in cholangio. But the efficacy in HCC is just not as impressive. But, there are some that doing it. But, I think we just haven't really taken on that as a program here. I think we also have like other options, and really the transplant for HCC, which is like much further developed. So it wasn't really something that we think was as helpful as like for patients with colon and intrahepatic cholangio.
Thank you very much.
Thank you. If I may ask one question, Dr. Gholami, I know we didn't talk about transplant today, but probably I won't get that answer even in that talk because it's more HI focused. So in the path of transplant, where is the role of HAI?
Yeah, I think it depends, right? Like the transplant selection, I think, would be focused on patients who have control of disease at least for a year. I think I would exclude the ones, that have BRAF mutations. I think the right-sideds, again, do a little worse, so we have to be very careful, probably extend that time. So if you look at the protocols across the US or even in Canada with all the experience, and even you just have to be very selective and make sure that they really respond. So the way I look at this is whether it's Y90, whether it's ablation and resection or anything, like this regional therapy should be like the pre-transplant to control the liver disease, right? Like for as long as you can push it out. Then you've really tested the biology of those patients. And then you self-select, right? Because I think chemo alone is tough on these patients for a year plus. And so there was actually a recent paper by the group in not Mayo, I think it was actually Cleveland Clinic. They just published this like about 2 months ago. And it's really nice because they show that their transplant patients are very heavily treated. So they had 3 with HAI, they had a few others, I think 5 or so with like Y90 and other things. And it's just, again, to try to prove biology, right? In addition to the systemic. So I see it as a bridge, where, and where exactly, and, there's some patients who will never be a pump candidate, and that might be a better transplant candidate with, chemo alone, like getting them there. But I think the nice thing is like we have hopefully lots of options for these patients, which we didn't used to.
So like in HCC, does downstaging matters? And if it does, how long to wait after a downstage before you consider transplant? Let's say the tumor hasn't disappeared, but would you still consider transplant after a certain control?
Yeah, that's a good question. I think if a tumor is resectable, I would never transplant because if you even look at the transplant data that was just published by obviously Renee Adam, who's like one of the really best liver surgeons, I would say, in the world, and that has a tremendous amount of experience. Like their clinical trial on the, it showed that the survival is about 60 to 70%. So if you're, or like 50 or 60. So the numbers of resection is very similar, right? The fiber survival. So if a patient is resectable, I would resect. I mean, I think that's still, and then not waste a liver. But I think if you can just treat and it's still unresectable, and I would say at least a year. I think like 1 year is sort of what I've seen across for most of the protocols at the centers that are now transplanting, because that gives you enough of confidence that they're not going to recur. And, even in the transplant data, I mean, the data is incredible, but a lot of those patients recurred and then they were retreated, right? And I think the question is how much chemotherapy afterwards are they still getting? So there's some details still that is not very clear to me of what is really needed to control the disease, because if they recur at the same rate, then I don't know, have we really helped them? Because a lot of them are like post, either like ablated or resected or something, or have lung meds and then they're resected. Like, I mean, we do that right now in the real world. So I think before we start offering transplant to everyone, we just have to really understand the timing, like you said, of when would it be really appropriate. So probably at least a year. And then, if they're safe, then probably good to offer them.
So since there is a risk of recurrence, and you also saw some data about the neoadjuvant therapy. So after a clear margin resection, would you still do HAI in these patients?
I do. We do that in the adjuvant. And I tell you that because the risk of recurrence is high. I mean, it's 70%, and that really goes without default. I've had patients that I never thought they would recur, and 6 months later they're back, and you can't predict it. So I think that's really the challenge that we're having. Whether it's transplant or whatever. I mean, they recur outside. Obviously, the majority is in the liver, but they even recur outside. If you look at the transplant data, the lung mets are not infrequent, and the patients undergo resections and things like that. But I think the lung mets are easier to deal with sometimes, right? They're sort of like more indolent. They're not as, sort of like bad as like the liver metastases that come back. So there's definitely some differences that we're seeing.
Thank you. Lastly, I will pull out Dr. Mangesh Pragdala from Methodist Dallas.
So that's a great talk. In fact, I had no idea about this pump until I heard your talk today, and I should probably have my surgeons look into it as well and maybe get in touch with you for a program setup. But just a quick question. Does this giving intra-arterial pump for liver mets, has it had a good response to even peritoneal mets?
No, yeah, that's a good. So no, so we do not place it for patients with peritoneal because it really only goes to the liver. And so we try to avoid any extrahepatic disease. I think in the select patients when there's maybe 1 or 2 small lung nodules that you can radiate or you think they're just, beacon observed, I've definitely offered patients a pump, but definitely not with peritoneal. It just, the drug doesn't go there. I mean, it's as simple as that. And, when patients have even portal lymph nodes or retroperitoneal lymph nodes, we try not to offer them. I mean, unless the patient is desperate and you're really trying to control the liver disease, I don't think it's a direct contraindication, but when you look at the literature, you just know that if you have retroperitoneal lymph nodes, the chances of extrahepatic spread is just higher. And, the drug just doesn't get there, unfortunately. So you're not treating that directly. Now, I mentioned the pump is always given with systemic. So that's why sometimes it can still be controlled and it's not, so if you're really trying, if the challenge clinically is the liver and you have some nodal disease, it can be offered where the systemic helps the nodal disease and then the pump helps the liver. But in general, extrahepatic disease is a challenge.
And just a follow-up question, just hypothetically, let's assume that they get a liver transplant and, your concern is the data on recurrence. Is there any role for maintenance adjuvant therapy by hepatic artery pump just to prevent like maybe once a year or something post-transplant?
Oh, I don't know. I don't know that. I don't think we've like even gone there. You're like in 20, like 30 maybe, or 35. I don't know.
Right.
You know, I have no idea. I think it's going to be hard to make
Maybe
that.
you should just convince your colleagues to try that.
I
That's a
know,
good
yeah.
idea.
Maybe in 10 years. I think we're trying to still answer the pump and transplant question first, and then, but you know, I actually think the adjuvant data on pump is a lot better than the unresectable. We offer it a lot more to the unresectables because they have nothing else. So it's easier to sell something that has some toxicity and potential for, obviously, I mean, it's a surgery, right? And then even though the safety is okay, I still think that, you know, there's some risk with it. You know, it's a procedure. And so offering, and the complications with adjuvant pump are a little bit higher because you're manipulating, you're doing stuff in the liver. So the toxicities are a little bit higher if you compare it to but I think the results with the adjuvant pump are actually better. And so I think the way I sort of look at that is an even lower burden of disease seems to have a better outcome than a lot of meds. So maybe the drug just works better when there's low burden of disease and it can get rid of everything sort of, and sort of like, you know, clean up whatever is left in the liver and sterilize, so like say this the field versus, you know, having a bulky disease of unresectable, you know, which it can still shrink it. And we've seen some dramatic responses. I mean, I think Sandra, you know, is like showing you last week. I mean, sometimes I don't even believe my own eyes of like what we're seeing, but you know, the responses are still a little unpredictable. Like we don't know who responds.
And just a quick follow-up question, if you don't mind, then I'll let somebody else ask the question. Is, you know, it's just not resection alone, which, you know, is the treatment for liver mets, because there are some patients who can't be resected. We go for CERT, Y90, TheraSpheres. So is there any role for adjuvant hepatic artery pump with patients who are undergoing embolization and CERT procedures?
Actually, it's hard to do it's hard to do pump after Y90. And the one is the toxicity of the Y90 alone to the liver. So I avoid every pump in a Y90 patients. I would not place one. Also, the Y90 interferes with the blood flow, right, to it. So we don't really have good data, but I think that the flow to the liver is different and changed after Y90. So I think the results are just not going to be as good.
All right, thank you so much.
So Dr. Gholami, as a follow-up, maybe I can reframe the question Dr. Pragdal asked. With a transplant, you are taking the whole micrometastasis or anything that is there that might recur. That's my thinking is, so that with a transplant, probably you don't need a chemotherapy because you're taking the entire liver out. But in a resected liver, you may still have some micrometastasis, which was not visible. And then now you are using HI to completely eradicate. Is that true?
Yeah, but I think the circulating tumor DNA is in the bloodstream, right? Okay. So I think there's probably a mix. I mean, I think you're right, Sanjay, like when you're getting rid of the whole liver, there's probably a less of a recurrence risk, like just by nature. But I think that micrometastatic disease that could be anywhere, right? I mean, it's already spread through the lymphatic system and through the bloodstream to the liver. I think that's also another source. So you don't ever get rid of it fully.
So by doing HI, you are not eliminating those micrometastases outside Correct. The liver.
That's why you always give it with systemic too, right? Okay. I think it's a really dual thing. I mean, I don't think we can get rid of everything, you know.
Let me ask one, probably not liver related. I had a patient who had colon cancer and had liver disease and liver mets and you know, got EGFR, systemic chemotherapy, etc. And the liver mets really shrunk and almost disappeared. And then I did a colonoscopy and I couldn't find much cancer in the colon either. Do the people who have like such kind of response still need colon resection?
Yeah, it's a really good question. So we actually I think I was trying to show you that in the neoadjuvant space, right? If you get everything up front, your responses are better. And we know that even immunotherapy that doesn't work in the later stage works better in the early stage, right? Like that's why the rectal tumors that get the immunotherapy early, the rectal tumors disappear, right? So similarly, I think it can happen with colon. Can you avoid a resection? We don't have the data, right? So I think it's hard to tell a patient, well, I don't see your tumor, so therefore I'm just gonna watch you. I think with rectal, the watch and wait approach with rectal cancer is really nice, right? Because you have the MRI, you have the digital rectal exam, you have like endoscopy and the biopsy. So you have 3 different methods. And we do that here with watch and wait. We give the chemo, we give the radiation, we watch and wait. And we don't take until, if they have a full response, we let the primary be if it's completely gone and it's just
Yeah, but in patients who have early cirrhosis, etc.,
yeah.
we have all seen people decompensate and die after colon cancer resection.
Yeah. I mean, if you have early cirrhosis, is different. I think I'm just saying for the general population, we are trying to create a clinical trial to ask exactly the question that you're doing. Like this went actually through SWOG of can you give chemo, watch, and not do the colon resection? And I think the problem is that the colonoscopies, everybody felt that it's not enough and the CT scan doesn't show enough, right? Whether there is like a little bit or not. Right. And so I think maybe in a few years we'll be looking at it differently. But if you don't have cirrhosis or anything, honestly, a right colon is not that big of a deal in general, right? It doesn't have a high toxicity profile. So, and you can avoid maybe the chemo. So there are 2 thoughts. Some people feel that the surgery is like easier, but it depends again on your patient, right? If you have a very comorbid patient that's fragile and has cirrhosis, obviously, then avoiding a resection might be the better thing for that patient. So just
the other thing is we have currently 2 patients, alcoholic.
Yeah.
They had alcoholic hepatitis and they have underlying cirrhosis and they have colon cancer.
Yeah.
And in that situation, when and how do we treat these patients? Because,
I mean, I think if you have a colonoscopy and you don't see anything and
this is a new diagnosis.
Oh,
These are new cancers.
I see.
Patient has cirrhosis and alcoholic hepatitis. They stop drinking. Now they are recompensated within a couple of months. They don't have ascites or anything. But the surgery in this patient is still pretty difficult. What would your plan be for these kind of patients?
I mean, I think it depends. If really the liver disease is that bad, then all you may have is seeing to see what systemic options you have, right?
If they have portal hypertension and say platelet counts of 80,000 or something, do you?
For a right colectomy? Probably, I mean,
sigmoid.
Yeah, sigmoid. I mean, now you're making it harder. The next thing you're going to say rectal, and I say no.
No, not rectum. I have a patient right now.
I mean, honestly, I think it depends. If they can absolutely not tolerate any chemo, then I think, you just discuss it with the patient. And, I think robotically, you may not tip them over, but, there's always that chance. It's a hard question. I don't know if I can give you the right answer.
No, because we do see this, especially alcoholics, they come and sometimes they have colon cancer, they have fatty liver, they have mild alcoholic hepatitis, sometimes underlying cirrhosis. And this is not a very uncommon scenario.
Yeah. Maybe do that, tip them over, and then transplant. I don't know. Sanjay, what do you do?
We have to wait as any solid cancer for at least a couple of years before we can transplant them.
No,
but
I know.
Again,
the
science is evolving.
Yeah, but I guess here, if you had an advanced liver disease, and do the colorectal surgeons here do it, or what have you seen?
Well, we encounter it rarely. I don't know in my experience. I have only one patient we considered we didn't consider for transplant. I don't have any good experience in this area.
Okay.
Dr. Gholami, thank you. That was a fantastic talk, great discussion. It's, I think, a talk that probably has created a awareness, in many countries who have joined from different parts of the world. And I will continue to do this kind of effort. And thank you for coming and joining with us and sharing your knowledge.
Absolutely. Thank you so much for having me.
Thank you very much.
Thank you, everyone.